This conference will now be recorded.
Good afternoon and morning, everyone. Thank you for joining us for another installment of the ACRM Pandemic Webinar Series. I know everyone is super busy, so we'll try and make this a high-value meeting. Today's guest speaker, so last week we had two folks from the telemedicine industry and from CHI and the Nixon Law Firm. And then we had a representative from ASHA, and today we have joining us Alice Bell from the American Physical Therapy Association. She's a senior payment specialist. Alice is on staff as a senior payment specialist in the public affairs unit of the APTA. Prior to joining APTA in November 2017, Alice was actively involved in CMMI demonstration projects focused on alternative payment models and integrated care delivery models. She has a bachelor's from Northeastern University in Boston and MA and Doctor of Physical Therapy from University of Montana. She's board certified in geriatric physical therapy and has lectured and written many articles on topics related to physical therapy and the older adult. She's practiced in a variety of settings and has 37 years of experience as a physical therapist. Dr. Bell has presented at many national conferences. Her professional activities include serving as a member of the Centers for Medicare and Medicaid Services Technical Expert Panel for Skilled Nursing Alternative Payment Systems, the APTA Staff Representative for CPT Editorial Panel, APTA appointee to the NDHI Opioid Crisis Work Group, and the APTA appointee to the National Quality Partnership Opioid Stewardship Action Team. She's also the member of the National Quality Partnership on Opioid Stewardship Steering Committee and a member of the National Quality Partner Leadership Consortium. Alice Bell, welcome and thank you for taking time out in what I'm sure is very, very busy days at the APTA with everything that's going on.
Yes, thank you, John. I'm happy to be here.
Great. Well, we will get right to it. So I was getting emails late yesterday afternoon, and I'm hoping that you had a few minutes to, or a little bit of time to go through everything that's been coming out. So we'll just start with no disclosures. I'm going to let you. I'm following your lead. I'll advance the slides, but you tell me where to go.
Sure.
So just so everybody knows, the folks who are, if today's your first session, our focus is primarily on telemedicine, telerehab, e-visits, remote patient monitoring. How can you see patients? How can you continue to see patients? How can you keep your staff on staff? And how can you try and continue to have income even as you're closing your doors? We're hearing a lot of really interesting stories coming out of some groups that we're working with in New York, where gyms are inpatient gyms are closing down so that they can put beds in them. PTs, OTs, speech therapists are filling nursing roles on units. So really just very crazy times right now. We're also hearing in other parts of the country that people are having to furlough staff and are having to make some really hard decisions and have a lot of really uncomfortable and really lousy conversations with a lot of people. So they're looking for any options they can find on how to keep revenue coming in, how to keep staff engaged and occupied, providing care. And so that's the focus of this webinar. So just so if you haven't been able to tune in, which the last week's webinars are high value, all of them are available for download on the ACRM pandemic website, as this will be also. So if there are others, colleagues that would be interested, they can get the slides, they can get the links out to other resources available on ACRM's pandemic website. So with that in mind, and also if you have questions, please make sure that your phones are muted. And if you have questions, please post them into chat. We are going to leave time at the end so that Alice can field those questions. So Alice, take it away.
Thanks so much, John. And just a few introductory statements before we get started. First, I will make sure to leave more than adequate time for questions because I know people have a lot of them, and that tends to be the most valuable part of some of these webinars. As I go through the slides, I'll go through the initial slides fairly quickly. The presentation will be available to you after. But I wanted to just put some general context around what it is we're dealing with. And although what we are seeing is an acceleration of modification of policies and state laws and regulations in response to this crisis, what we are seeing is really I think a faster adoption of things that were coming down the pike anyway. They're just coming much quicker by necessity. And there was a gap when this crisis first hit where therapists were not able to see patients in their clinics, but they had no other alternative to offer. We're seeing changes to that very rapidly as well on a day-to-day, sometimes hour-by-hour basis. So I will go through some of that. In addition to the slides, I put together just kind of a quick key takeaway document, and at the bottom of that document is a link to a page that includes all of the resources that APTA has developed around these issues. So please go to that link as well. Much of the information, not all of it, but much of it is available to non-members as well as members. So John, you can go to the next slide for me. And I'm not going to read the objectives to you. They're here, they're available. Hopefully I'll hit them all, but I think the big one is really getting people to understand what your options are for care right now, how you execute on those options, and how you actually bill and get paid for those options. So we'll go to the next slide. And again, just to put some context here, the APTA House of Delegates passed a motion related to telehealth back in 2014. So for 6 years, we've been working really on increasing the access to telehealth for physical therapists as providers and for consumers and patients who are receiving telehealth services. You can go on, John. And we know that there are many ways that telehealth services, and I'm going to speak to telerehabilitation. We hear the terms telemedicine, we hear telehealth, we hear telerehabilitation. I'm using telerehabilitation just because it's very, very specific to therapists, and that's what we're going to talk about today. So this is really about being able to deliver services real time to our patients and to bridge gaps so that we can better address patient needs. And certainly those gaps have gotten much larger in face of COVID-19. Next slide, John. And I apologize, I'm a New Englander by nature, so I tend to speak rather fast. I'll try to slow it down a little bit. But we not only have this issue of telehealth, something that we've been working toward, telerehab, like I said, since 2014. Now we're faced with a disaster, and that being defined as a serious disruption of the functioning of a community or a society involving widespread human, material, economic, or environmental losses and impacts in which the affected community or society is not able to cope using its own resources. So whether you look at the macrocosm of the world in this disaster, or you look at the microcosm of physical therapists and physical therapy practice in this disaster, we are certainly living a disaster right now in terms of our ability to cope using what have been our existing resources to meet the needs of patients. Next slide. And so some time ago as well, APTA really looked at what the role of physical therapists was in responding to federal and state disasters. And so one of our charges as a professional association is to really assist our members in mobilizing and providing relief and to augment what's happening through the federal government and state and local governments to ensure that our members can execute on whatever provision of services and resources they're able to provide. Next slide. So obviously the type and magnitude and location of the disaster will dictate the resources that'll be needed. we are dealing with an enormous issue now in terms of type, magnitude, and location. And so it's requiring an extensive amount of resources at every level, and we are addressing that as quickly as we possibly can in terms of supporting our members and supporting individuals who interact or who employ physical therapists. Next slide. So we have an infrastructure, for those of you who may not be aware, within the American Physical Therapy Association, where we have our national association and then we have state chapters. Certainly in many of these issues, the state chapters are best situated to assess the needs of a community and determine appropriate responses. So we are working very closely with our state chapters and their leaders. The other thing is that just as in politics, a lot is local, in payment, a lot is local. So there are local payers, there are state Medicaid policies, there are a lot of things that are controlled at the state level. So as we work with national payers and with federal payers, we also are working very closely and aligning our efforts with our state chapters as they work with local payers, state policies, governor's orders, and those types of things so that we can coordinate those efforts and give the best support and recommendations to our members. Next slide. So we know, and we have known for some time, that telehealth can empower both patients and healthcare providers to offer the best approaches to care. There are a lot of factors that we have to consider in terms of the patient themselves, their geographic location, the diagnosis, what their resources are, both technological resources as well as physiologic and cognitive resources, and financial resources in terms of what payment options are available. But we know this works. We've got a number of studies, and those studies have accumulated over the past several years. And we have strong evidence that this is a meaningful and effective mode of delivery. Given that the therapist has the resources and is able to determine the appropriate patient and which patients in the trajectory of their rehabilitation are going to benefit. In this specific instance, where it may be the only option, even for those patients who it may not be the ideal mode of delivery, it is a means by which we can help to mitigate risk and prevent patients from experiencing losses in their rehab trajectory by engaging through these models. Next slide. We know that we can reduce disparities in care. It was up until a month or so ago, especially in rural communities. I would say as we sit here today, the risk for disparities in care is across the nation based on a reduction in access that is significant for most potential consumers and patients. And although in many cases it doesn't eliminate the need for in-person visits, again, at the time we're living in today, it may in fact be some form of a replacement and be the only replacement option for many patients. Next slide. So this is something that APTA put together very specific to COVID-19 in terms of kind of understanding how physical therapists can play a role in the various phases of managing this public health emergency. So we do have the ability, and I also want to qualify that although there are many physical therapists who are not seeing patients face-to-face right now, there are a number of physical therapists who are absolutely engaged in direct care in hospital settings, in rehab settings, in skilled nursing facilities, even in outpatient settings and in home health. And so as we're seeing those patients, we have the potential to help to move patients through the continuum of care more quickly, help to get them out of hospitals and free up hospital beds by making sure that we optimize their independence and their ability to transition as quickly as possible. We also play a significant role, many physical therapists, in treating the cardiorespiratory system and looking at how we can help patients who may have a need for mechanical ventilation in terms of reducing the need and duration of that. and also the opportunity to mitigate the risk for patients requiring that level of care. Next slide, John. In the response phase, as we're seeing the demand for ICU and ventilators potentially outweighing the supply, we can look at treating patients who have cardiorespiratory conditions associated with the virus. And again, as I said before, look at opportunities to reduce either the need for mechanical ventilation or reduce the duration. Next slide. And I think critically important as we think about when we move into the recovery phase of this situation, and in some communities and with some patients, we are moving into the recovery phase. Many of these patients are going to have some long-lasting effects of the impact of COVID-19 on them physiologically, and the role that we will play in improving mobility and function and getting these people back to their prior lives as quickly as possible will remain significant. Next slide. So as I said, this is not a new concept, but one that we can certainly leverage in these challenging times. You can go to the next slide, John. I'm going to dive in a little bit more into the various means by which we can provide care today, but I want people to just think a little bit about this, because I think traditionally we think about physical therapist care as kind of a list of procedures, and part of that is because of the way we bill for the care we provide, and CPT codes describe.
Your phone, please. Sorry, Alice.
That's okay. Describe services and procedures. But what we do is much more than this list of procedures. And we examine, we evaluate, we diagnose, we consult, we advise. We identify compensatory strategies. We promote meaningful movement. We educate, we support, we empower. We modify environments to promote optimal performance. And ultimately, we promote self-efficacy. And many of those things can be done via a means that is an alternative to being in the same room with a patient. And so although there are things we can do procedurally, there are also many, many things that we do that are inherent to our practice that can be done very effectively using technology. Next slide. I'm not going to go into this example in the interest of time, but I did include an example in the slides that you can look at. And this is before COVID-19 and how telerehab might work and how it can actually support a patient who's been through some sort of a traumatic incident. But in the interest of time and getting to kind of meaningful information as well as your questions, I'm going to just have you move through those slides, John.
Okay.
Because they can look later at this. And you can move through this one. I do want to give a couple of the e-visit examples because this is a new concept to us as physical therapists. And I think it gets a little confusing because the word visit exists in this code description. An e-visit is not a visit as we understand it. An e-visit is a means by which we can maintain contact with our patients and support them at a point in time in which they cannot access our actual treatment. So we are not actually providing treatment. We are really more acting in the role of consultant, advisor, and working to support patients through the utilization of these interventions. So a couple of examples, and again, I also want to reiterate that from a Medicare perspective, the online patient portal is still a requirement. Early on, CMS was indicating that they would be flexible with the type of technology used to deliver these e-visits. However, the MACs have not adopted that level of flexibility, and we are working daily with CMS to get them to get a communication to the MACs. But we encourage therapists to speak with the MAC to see if they are waiving the requirement for an online portal. Now, some new options came through in the rule yesterday in terms of allowing us to use the telephone connection codes as well as the virtual check-in codes. So that gives us an opportunity to use other technology besides an online portal. But for the e-visit, it is an online portal. So for example, you have a patient who you've been seeing. Now they're not coming into the clinic. They contact you through the online portal and they tell you that they're having difficulty performing one or more of their home exercises. So using the portal, you can reach out to that patient, ask them to provide details, and then also using the portal. So you reach out to them and ask them to provide details. They use the portal to respond and give you that information. You reevaluate their program and you make a clinical determination to modify, replace, eliminate, or downgrade their exercises, and you send that upgraded program to the patient. You are not getting into any video chat with that patient. You are basically giving them a supportive recommendation based on sharing information. John, can you go back one? I'm not sure if we skipped one. Yeah, so I want to talk about this one. You have a patient who's recently had a knee replacement. They're concerned that they're experiencing some decreased flexibility in their postoperative knee. They've missed a few appointments. Using the portal, once the patient has reached out, because this is a patient-initiated contact, the PT then can, through the portal, ask the patient to describe the movement-related changes. Are they having more difficulty getting out of a chair? Are they not able to move their foot back as far when they're sitting in a chair? And then you can ask the patient to keep a diary, a 24-hour diary of their activity and exercise, and then review that diary that is sent to you through the portal. You can determine that the patient may be sitting too long throughout the day. They may not be performing the exercises as frequently as you prescribed them. So you can use the portal to basically kind of reboot this patient's program, give them with a specific schedule of exercise and activity, and advise them to check back in a couple of days. When you're billing an e-visit, you're billing the amount of time that you spend over a 7-day period. So you might have multiple exchanges and interactions through the portal with the patient over 7 days, and then you're going to select the appropriate code based on the amount of time. So whether it was 5 to 10 minutes, 15, greater than 10 minutes, or greater than 21 minutes, that is the code that you would select. You can go to the next slide, John. All right, so let's get into coding and billing and what we're dealing with. And I'm actually going to, let's do it this way. So right now, under Medicare, physical therapists are still not recognized as eligible providers of telehealth. That would mean our ability to use our traditional 97,000 series codes and bill them under a telehealth visit is limited under Medicare. Now, what's interesting is in the rule that was released yesterday, CMS announced that they have added 97,000 series codes to the list of codes that can be billed via telehealth. However, we are still not an eligible provider. So even though the codes are there, physical therapists cannot bill them. What we believe happened is this rule dropped before the CARES Act was passed. And the CARES Act is what gave CMS the authority to add physical therapists as eligible providers. So now we have reached out to CMS and we are requesting that based on the CARES Act, that they apply the waiver that would allow physical therapists to be added as eligible providers. You'll see on the APTA website under the link that I've sent to you already, or that I included on the handout, there is a template letter there for physical therapists to use to send to CMS. Obviously, APTA is speaking with CMS multiple times throughout the day and working to get this facilitated. But it's important to understand this because it's very confusing. Our codes are now approved, but we are not. So before we can bill telehealth under Medicare, we have to get included as an eligible provider. However, we are seeing many commercial payers change their policies, some in response to state orders, and some in response to their own policy movement, to include our codes as codes that can be billed with telehealth. It is different for every payer in terms of which codes. We've seen some payers adopt just our evaluation and reevaluation codes. We've seen some adopt our evaluation and reevaluation codes and one procedure code, usually therapeutic exercise. We've seen others adopt only the procedural codes and not the eval codes. So it's very specific to payer policy. APTA has posted a website. We are keeping a running Excel worksheet of every payer policy change as we are made aware of it, and it is changing quickly. The other thing that has great variability is how you then bill those codes. What modifiers do you have to use? What place of service code do you have to use? What technology has to be used for the delivery of the service? So these are moving targets right now. It's really important that you understand what's in your payer policy. As I said, the resource that we have posted includes kind of a general summary of what the payer is saying, as well as a link to their policy so that you can read the policy in its entirety and understand what options are afforded to you. But we are certainly seeing rapid movement in terms of local payers and Medicaid. We're seeing a lot of activity on the national payer side. The clear policies thus far have been posted by Cigna, United Healthcare, and Aetna. We are in direct communication with Humana right now. We have been since last week, and we're continuing to communicate with them to encourage a change in their policies. We've seen several of the Blues at a state level adopt policy changes. So there's a lot happening. It's happening very rapidly. I would say we've seen the greatest adoption occur over the last 48 hours. So we will continue to update our resources and encourage you to access those resources as well as your payer policies. Next slide, John.
So Alice, I just want to ask, so before we move off this, I think this is really interesting. I mean, that announcement, I saw it maybe a half an hour after I got off the phone with you, where I was speculating, do you think those codes will come out in, a week, 10 days, 2 weeks, and then bam, there were the codes.
Yep.
But it sounds like they maybe got their communication channels crossed. So being at the eligible provider list, I mean, I think the codes are good now because those can be used for United and others that have already cleared the decks for ancillary clinicians to build telehealth services, right? They've lifted. I mean, the eligible provider ban is still in place for CMS, but United.
Gas.
Sorry,
Yes.
Can you mute your phones, folks?
Diagnosis?
Please mute your phone if you could.
I did record a few.
You did?
Whoever just said diagnosis, if you could mute your phone. Thank you.
Yeah.
Sorry, John.
So so they can use those now, right? I mean, like they would be able to use those, because that was part of the problem, was that there weren't telemedicine codes. And I don't want to throw you off on this. I just want to digest about the fact that they've kind of provided the content, but they haven't opened the gates yet.
Right. And it's an important question, and so you're right. This historically has been the question: is what are the telehealth codes for physical therapists? And APTA has maintained that it is our existing code set, that it is our 97,000 series. When you talk about actual physical therapy treatment, those are the codes that describe the procedures we provide, and with some exceptions like manual therapy and aquatic therapy and our modalities, which obviously cannot be provided through a video component with a patient. Our other procedure codes certainly can be delivered in that way. And now we have some of these digital medicine codes and communication-based technology codes that prior to this situation, physical therapists were not considered eligible users of those codes. Even CMS has opened that up, and I'll talk about that in a minute, in terms of e-visits, virtual check-ins, and telephone codes. The 97,000 series codes on the commercial payer side, for some time now, there have been providers who've been able to build those codes. Some of it has been specific providers who've been able to negotiate agreements with payers that they could provide those services via telehealth. Sometimes it's been through employer-sponsored plans. The VA, certainly, physical therapists have been doing it for some time. So we really didn't need Medicare to add those codes to their allowable codes in order for the commercial payers to let us do that. And as a matter of fact, Cigna made a decision to add those codes prior to, and so did United Healthcare, prior to Medicare updating their rules. So we already had that door open. The challenge with Medicare, as I said before, is they did what they could do under their authority when they put out this new rule. Now that the CARES Act has passed, they have greater authority to change eligible providers, and we are strongly encouraging them to do so as quickly as possible.
Great.
Does that answer your question, John?
It does. It does. Great.
Okay. So, and again, the one thing I would really strongly encourage you, what's really important with these commercial payers, again, is just because they say that PTs can bill their codes, it doesn't mean all of them. You've got to know which codes. And again, as I said before, it varies by payer. Some of them, I think 100% of them at this point are saying use the place of service code 02. That's very consistent. So place of service is consistent. Modifiers is a little more variable. So some are saying 95, some are saying GT, some are saying GQ, some are saying we still need our GP modifier, others are saying we don't. So you really want to look at the policy in terms of what modifier. Luckily, we were able to kind of get in front with the commercial payers and make sure they included that in their language. Don't just tell us we can bill, tell us what place of service, what modifier, because otherwise these bills are just going to get kicked back. So make sure you understand that. Next. So now we get into these non-face-to-face or what's called communications technology codes that exist in CPT and also that in some cases Medicare has developed HCPCS codes for. So we've got CPT codes and we've got HCPCS codes. What we saw early on, the middle of the month, was that Medicare gave physical therapists access to the e-visit codes. And I've talked about that a little already. As of the rule last night, they've also given us access to the telephone service codes. They have not yet given us remote physiologic monitoring, and they have given us access to the virtual check-in codes. For the virtual check-in, it's HCPCS codes that we have to use. There are G codes that Medicare has developed because the CPT codes are E&M codes, so we're limited from using those. The telephone services, we actually have our own CPT codes. We have had them for a while. We've just not been allowed to use them, or there has not been any payment for them. Now there will be payment for them, and physical therapists are allowed to use them. And so in terms of providing some clarification for you, and I apologize, just give me a moment here. The various codes, the telephone codes are they're non-physician qualified healthcare professional codes, and the virtual check-in codes, like I said, are HCPCS codes. They're G codes. The use of the telephone code speaks for itself. It's a telephone call with the patient where you can support them just like you might through an e-visit. The difference is you're not billing time spent over a 7-day period. You can bill for each telephone interaction that you have with the patient. The virtual check-in codes allow the use of a variety of technology. So it can be a video, it can be a telephone, it can be, well, I guess those are the main ones. So video conferencing, telephone. And as you know, what CMS did early in the month is they've relaxed a lot of their HIPAA requirements. So that applies to these virtual check-ins where they're allowing things like FaceTime and Skype. Anything that's a private-facing technology, you cannot use public-facing technology like Facebook. So that kind of gives you a general sense of where we are with those things. So let me see. Next slide, John. Okay, so what's next? Basically, we are extremely hopeful and will be incredibly persistent about getting CMS to address the issue of eligible provider so that physical therapists can bill the 97,000 series codes and actually provide telehealth benefits or telehealth visits to Medicare beneficiaries. We expect to see continued adoption by commercial payers in terms of expanding the offerings that physical therapists can provide and the codes under which they can bill for both virtual services as well as telehealth. And then the question will be, what happens after all of this? How many of these policies go away when this emergency goes away, and how many of them remain after this situation? And I can tell you that at least on the commercial side, we know that many of the commercial payers are looking at this as almost a forced pilot, and they'll be making some long-term decisions based on how effectively providers execute and what we see in terms of cost of care, outcomes, patient satisfaction, and a number of other factors. So I put that out there because it is an opportunity for us to see adoption of these policies on a longer term more rapidly than we would have otherwise seen them. So we're about 3 minutes away from getting into our Q&A time, but I'm going to cede over those 3 minutes, John, because I have a feeling the Q&A is what's going to be important for a lot of people.
Okay. That's a great session, Allison. I know that it's a lot of information to be staying on top of because it's changing very rapidly. So thank you for the overview and the summary and sort of catching people up on, there's a lot of people that we're talking with and they're trying to come up with long-term plans.
Yeah.
And then resurgence and how we're going to deal with this in the fall, if it dies down and then it comes back, and what's the role of ancillary services and all of that. And, as you said in your slide, I don't think there's anybody else in the hospital that's better equipped or better positioned to help get patients out of beds, get home safely, transition between care settings than PTOT and SLP. So we'll open this up. Let me scroll back up to, so the first one is from Carrie, is the APTA's understanding that the new updates regarding e-visit and telehealth billing during this pandemic is only available to private practice therapists and not to hospital-based clinics?
So that is correct for the e-visits. And again, this was some confusion in terms of early messaging that we were getting from CMS and what they're telling us today. So right now, the e-visits and the virtual check-ins, and we're seeking clarification on the telephone services, but the e-visits and virtual check-ins are limited to private practice providers. They do not apply to institutional settings. If we get the true movement to telehealth that we are hoping for and anticipating, then that would be available to institutional settings. And CMS, in their guidance in this new rule, and we've got a quick reference sheet on the APTA website, has issued guidance for inpatient rehab facilities, for home health agencies, for skilled nursing facilities, and on the hospital side, one of the exceptions is critical access hospitals who can bill the e-visits. So it's a moving target a little bit. On the commercial side, we are still seeking clarification. We spoke with one of the large national payers yesterday in terms of how a hospital-based outpatient department would be able to bill some of these services. They said they're looking at that right now and expect that they're going to need to add a revenue code for institutional providers.
Okay, that's interesting. But what you're saying, I want to make sure I'm understanding this. So when they come out with the telehealth lift, that will clear hospital-based therapists for e-visits, and the the check-ins as well?
No, not for e-visits and check-ins. But what I was saying is, if we get a broader adoption, if we see physical therapists identified as eligible providers of telehealth, then we would expect those services would be able to be billed. But CMS has basically said that they do not recognize hospital-based outpatient as eligible providers for e-visits or virtual check-ins.
Okay, I'll sit here and try and understand that one.
So the issue is really around how we bill for those services. So because these services have to be billed under the individual provider's NPI and not an institutional NPI, that's the problem.
Oh, okay. Okay. So then the next one, is there reimbursement for PTs for remote patient monitoring, Medicaid, private payers, and is the APTA encouraging the approval of PTs to bill codes such as 990, 9153, and 457?
So the remote physiologic monitoring codes are codes that we have been pushing CMS to allow utilization of for well over a year now. They have not wrapped those in. So the first approval we got was e-visits. Last night they gave us virtual check-ins and telephone. They still have not given us remote physiologic monitoring. APTA has always encouraged therapists, or we have encouraged therapists over the last 2 years to check with commercial payers to see if they could bill those codes. And I know there are some therapists who have been able to do that, but it is not a widespread policy adoption at this point in time. Okay. And part of the challenge too with the remote physiologic monitoring codes, just so people are aware, is it has to be an FDA approved medical device that's utilized. So not all of the apps that we might find useful in terms of transmitting data that our patients may use are approved as FDA medical devices. So there's kind of a two-pronged issue to that. One is, can we bill it? And the second is, do we have an appropriate device for which to bill it?
Okay. So the next one is some examples of portals available to use.
So we have not endorsed any specific portals. However, our first council, so again, if you go to that link that I gave you, has put together some recommendations on portals that are available. Some of the payers have their own portals that they can make available to providers. And Connect for Healthcare Technology has also listed some portals, but probably the best thing would be to go to the resources that we have, to that link that I gave you on the APTA website, which will at least be a starting point. Okay,
great. And then from Catherine, are there guidelines for pediatric providers that need to work on facilitation of developmental milestones?
Yeah, so there's a couple of things. Certainly in the language around the telephone codes and the virtual check-in codes, it speaks to patients and or caregivers, parents in the case of pediatric patients. So for those services can apply when you're working with a caregiver or a parent to facilitate what the parent can do in terms of promoting those neurodevelopmental milestones. In terms of actual treatment, again, it would be dependent on the payer. We have seen school systems for school-based therapists who have adopted telehealth as an option and an option for delivery. We've seen some state Medicaid programs adopt it for their pediatric population. So we are seeing movement at both the state level, at the school-based level, at the commercial payer level, not yet under Medicare. I hope that answers that question.
Okay.
And I would offer, I'm sorry, John, I would offer also, if you go to that link that I gave you to the APTA website, there was a webinar that was done recently, I believe it was last week, and in that webinar, there's some examples. One of the presenters was a pediatric clinician who gave some examples of providing services via telehealth.
Excellent, great. And we'll be posting all of those links up on the pandemic site after the show. Alan Lee posted out the action plan from the APTA. So that's available in the chat, but we'll also make that available. There's a pediatric town hall APTA, pediatric APTA town hall coming up. So thanks, Alan, for posting that in.
Thanks, Alan.
The next question, oh, it just jumped. Go back. Does the POS change based on your location? For example, hospital-based versus outpatient, hospital-based outpatient versus private practice. So the place of service based on your location. I'm assuming.
Yeah. So I apologize, John. I kept interrupting you. So I want to clarify this. So place of service only applies to true telehealth. So if if we're billing those 97,000 series codes under telehealth, then that's when we use place of service. Or I'm sorry, that's when we use place of service 2 when you're actually doing telehealth. When we look at something like the e-visit, the place of service is based on where the provider bills from. So if a therapist has a bricks and mortar facility, then the place of service for an e-visit would be 11. If it's a therapist who works out of their home, then it would be 12. But that's just for the e-visits. When we're doing telehealth, regardless of where the provider is, and again, we're seeing changes in the whole requirements of originating site and destination site and all of those things. But for every instance where you're billing telehealth, unless otherwise directed, the place of service code is 02.
Okay. This is from Jessica. Telehealth at this time are only for unregulated private settings, then not for regulated hospital-based billing. Is that correct?
So again, it will vary by commercial payer. When we reached out to the commercial payers, so let me back up for 1 minute here. So we got the directive. The first directive in all of this actually came from CMS, and it was about the e-visits. And originally, when CMS put those directives out, they referenced both non-institutional and institutional claims. They talked about using the condition code DR and the modifier CR on institutional claims. They then pulled back from that and more recently have said to us the e-visits can only be billed on a 1500. So if you're billing on a UB, you cannot bill an e-visit. On the commercial payer side, because we experienced that confusion with CMS, as the commercial payers started putting out their guidelines and they started referencing place of service codes and modifiers, we asked them to please clarify what entities who bill on a UB04 should do. How should they identify the services as being provided via telehealth? And that's when we heard back really in the last 24 hours from the commercial payers saying that they are looking at that and thinking that they're probably going to have to add a revenue code. The big problem that institutional providers have right now is if you're billing on a UB, there's no way for you to kind of identify these services, or at least we haven't gotten good enough direction from the payers on how to identify these services to ensure that the claim is not going to get kicked out or denied. So that's why we're encouraging people either to reach out to the payer directly and get some guidance in writing. If it's a local payer and you have a connection and you think you can do it faster than we can, we are working on this hour by hour, literally. But the only providers that we can give absolute clear direction to, as I sit here at this moment in time, are individuals who bill on a 1500.
Okay, but so it sounds like the intention is there, and
Yes,
it's moving that way. It's the vehicle that
yes,
they are, the mechanics of it are what have to be ironed out.
that is correct.
Got it. Okay. So if CMS doesn't recognize hospital-based clinics, are the private insurances following those guidelines, or are they allowing hospital-based clinic billing, kind of adding on, you know, to what you were just talking about? I don't know if that, I feel like, do you want to add on to that, or is that?
I think I answered it. I hope I did.
Yeah. Thank you. Thank you, Alice, for the update on the RPMs. Business associates. So Alan posted business associates agreement is a must. I thought that was one of the. I mean, I think having a BAs and with all of your vendors is a good idea. Was that one of the things that was relaxed with the? I thought that was one of the things that was relaxed with the HIPAA documentation. No.
Not to my knowledge.
Okay. Can you verify a telephone interaction with the patient? Sorry?
I'm sorry, John. I just want to add one point too. I think it's really important to recognize this as well. Although CMS and many of the state orders, governor's orders, et cetera, have said that they're relaxing HIPAA requirements, we are still bound by being as compliant as we possibly can, and for no flagrant kind of non-consideration of HIPAA. And so we really still have to maintain as much level of confidentiality as we possibly can. So if we have HIPAA compliant resources available to us, we should be using them. And if we are forced into a situation of using systems that are not as HIPAA compliant, we should be doing everything in our power to make it as HIPAA compliant as possible. So if we're having a telephone conversation with a patient, not using speaker phones, making sure that we're in as private an area as we can be. We still have to be mindful of HIPAA, even though there's some relaxation of the standards.
Of course, yeah. No, I think that's a point worth mentioning. Can you verify this from Rose? Can you verify a telephone interaction with the patient is not telerehab, but instead considered a communication technology-based service? Yes. And to be considered telehealth, telerehab, it must be audio visual in all caps.
That is correct. Now it gets a little confusing because some folks in this world, and Alan may want to comment on this, but some folks in this world consider these communication-based technologies to kind of be a subset of telehealth. Medicare has a very strict definition of what telehealth is. And so under the Medicare definition, these communication-based technologies fall outside the realm of telehealth. When you speak to other entities, they may consider these kind of inclusive under that larger umbrella, but traditionally telehealth involves some video connection between the provider and the patient.
Mm-hmm.
And John, could I just provide one other clarification? Because I think earlier when we were talking about telephone, and one of the participants asked a question, and they referenced 99441 to 99443, and I just want to clarify that those are the telephone services for physicians. There are separate codes. The 98 codes are the codes for non-physicians. So just make sure that you're looking at the right code set, because there's two sets of codes for telephone services, one for physicians and one for non-physician qualified healthcare professionals.
Okay. Jessica, also to clarify, only unregulated settings, private settings can bill for e-visits, correct? And do e-visits have to be provided only via portal to confirm, or other means? Do they have they relaxed means of transmission of info or maybe they will in the future, question mark?
So for Medicare, I think it's highly unlikely that they're going to change now that they've added our ability to use the telephone codes. I think they're going to stick with the online portal requirement for e-visits because they've given us an option to use the telephone with the telephone codes and the virtual check-in. So I could be wrong, but I'm not expecting Medicare to change. On the commercial payer side, those commercial payers, oh, I'm sorry, I'm getting feedback. Are you hearing that, John?
A bit.
Yes, this is Terry. I am monitoring that, but I'm having difficulty identifying where that came from. So again, a reminder, if everyone could put their devices on mute, that would be most helpful. Thank you.
And I apologize. I'll do my best to thank you for that. So on the commercial payer side, for those payers that have adopted e-visits like Aetna, they have, in some of their policies, they have said that they will not mandate the online patient portal, that whatever means by which you're able to connect with the patient is acceptable. But again, that's why this is so challenging. I wish I could give you a 100% definitive answer across the board for everything. But like our life was prior to COVID-19, every payer has their own policies and their own rules. And this situation, unfortunately, is no different. I would encourage you to go to the resource on the APTA website because we've done our best to give you kind of the key points of each of the payers' policies and then a link to the actual policy.
Mm-hmm. So then I have, I don't know that this is a question, more of a statement. Some payers, Cigna, are reporting they are only going to pay for oral motor code 92526 for an SLP to provide, not an OT, even though this is under their scope of care, and maybe the only trained provider that provides this service at the clinic.
Yeah, Cigna has been very specific in the codes. So they've basically given each therapy discipline, for PT and OT, there are eval codes and one procedure code, and for speech, they've given them 2 codes. It is what it is. I would encourage, on the APTA side, we're continuing to communicate with all of those national providers national payers, and getting them to, consider expanding the code set. I would encourage ASHA or in this case, I would encourage AOTA to reach out to Cigna to make the case for why that code should be available to OTs as well. I think each of the professional associations, I know we've had calls where we're together collaborating our efforts, but then there are also very unique asks that are specific to each therapy discipline, and I think each professional association is going to have to take on some of those battles.
Okay, so we've got from Jenny 2 questions. Do telehealth PT sessions count toward patient session caps, and are all these policies also applied to PTAs?
So under, and again, I'm going to make the distinction between telehealth and these communication-based technologies. So when we look at the communication-based technologies, at least definitely with the e-visits and the virtual check-ins, and I'm seeking clarification on the telephone, but e-visits are limited to PTs only. They do not include PTAs. Under telehealth, generally it's been PTs and PTAs, but it's dependent on the supervision requirements. So, and some of those supervision requirements are being waived at either a state level or a federal level as well. But the thing you just need to make sure of is that you're in compliance with whatever the supervision requirements are. In terms of them applying to the cap, if you're speaking about the Medicare threshold, it's basically not applicable because we're not telehealth providers under Medicare, at least as we sit here in this moment. Under commercial payers, if there's a visit cap, then likely, yes, they would apply the telehealth visit to the visit cap.
Got it. Okay. And I think that wraps. So Again, Alice, thank you very much for taking time out of your with everything that's going on. I know that you are very busy. It's been very informative. Alice Bell, everyone, and again, the content will be posted on the ACRM page. On Thursday, we're going to have the AOTA, and then Friday, the Southeastern Telehealth Resource Center. So stay tuned for more information coming out 1 p.m. Eastern on Thursday and Friday of this week. So Alice, great having you on. Doing
Thanks,
great work.
John.
You know, feel free to post information that comes out of comes to your office, and we'll get that out to our members as you know, as it becomes available.
Thanks so much, John. I appreciate it. And thank you for facilitating the questions. That made things much easier.
Oh, great. Everybody try and stay safe, and we'll see you in the next show.